So it gives me great pleasure now to introduce Professor Lesi for our next talk, and she's going to be addressing call for action. We need high quality data to plan services. So Professor Lesi is well known to us. She currently leads the hepatitis B team in global HIV, hepatitis and STI programs at the World Health Organization, and coordinates the health activities in collaboration with other WHO departments to provide technical and strategic support for viral hepatitis elimination in countries. And she's really been a very strong proponent of the public health approach and actually getting it off the ground.
Thank you very much, Wendy. It's a real pleasure to be in South Africa again, amongst wonderful friends and colleagues from South Africa who have been working on viral hepatitis in the past 2 decades or more, before viral hepatitis became a public health threat. I think we should even give them a round of applause. We've done an excellent job. So I've known Wendy for over 10 years, and I stand here today, I wear 2 caps as an African hepatologist and belonging to an association of professional hepatologists and healthcare liver lovers in Nigeria, over 100 people strong, and many of them are online now listening to this. But this presentation I'm giving on behalf of WHO, where I now work, and I work in the global level and coordinate hepatitis activities at WHO. I want to thank the organizers for inviting me to give this talk. And I would go very swiftly on the need for data to plan services and call for action. So this is an outline, and I would like to deliver 5 quick points in the allocated time. So this is the Global Health Sector Strategy in June 2022, this year, 4 months ago. The new Global Health Sector Strategy for viral hepatitis, HIV, STI was endorsed, and it reaffirms the ambitious goals for elimination by reducing new infections and deaths by 90% and 65% respectively compared to the 2015 baseline. Now, this new strategy is the second for viral hepatitis, and it builds on the initial strategy of 2016, and it maintains a public health approach, and it has been designed in the context of the COVID pandemic and the new advances in science and technology. The new strategy and the old strategy had data as important strategic directions. As highlighted by the previous speakers, the impact and coverage targets to reach 2030 has been well defined, and the new strategy identifies the 2025 and the 2030 targets. And would you believe 2025 is in 3 years' time, and 2030 is in 8 years. So we have a lot of work to do. The new strategy identifies the targets, the coverage, the milestones that we need to tick off and achieve by 2030. The World Health Assembly asked to receive progress reports in 2024, 26, 28, and 31, noting that these progress reports are being made by WHO to report on their acceptance of these strategies. So, understanding the epidemic and response requires data and information. And both Wendy and the previous speaker gave us a lot of information on what? On data. So we're looking at wide regional variation in burden and response. 80% of people do not have access. 10 million people were on DAAs. All of this is data. So there's a wide range of data sources, including medical records, vital statistics, surveillance data, disease registries, literature, administrative data, economic data, model data, a whole variety of data. But I want to put it to you today that data and information provides a basis for advocacy, for political commitment, for policy in countries, for planning, for mobilizing resources, for implementing programs, for improving programs. So without data, we would find it difficult to make progress. As highlighted, elimination in the strategy is defined through implementation of 6 core interventions and related services. There are many interventions for viral hepatitis B and C, but the 6 core interventions that have been modeled to reach elimination are those we are familiar with and are shown on the screen. On the right side, 10 core indicators and coverage to deliver impact have been defined by WHO. And what you see in the blue, in the little blue box on the right, is the cascade of prevention, testing, and treatment data requirements. Now, how do we report data? So the reporting systems to be used to monitor service coverage and impact are shown on the screen. You would see that some of these interventions are pre-existing. The hepatitis B vaccine is over 30 years old. Systems for evaluating vaccination exist in the WHO UNICEF joint reporting forms. Systems for reporting harm reduction exist in the UNAIDS Global AIDS Monitoring System. But there has never been systems to report hepatitis B and C testing and treatment. And therefore, it defines the need for a new reporting system beyond what is already available. To this effect, WHO has developed a global reporting system for viral hepatitis, which was established in 2016 and 2017 as a web-based DHIS2 module, which is located on the WHO Integrated Data Platform. Now, this system was established to monitor progress towards the targets for viral hepatitis, and it includes monitoring and evaluation framework to capture data on critical policy uptakes. It is anticipated that the reporting will be from facilities, NGOs, private sector, through the 194 WHO member states to WHO, and a dashboard and platform has been provided for use and analysis of the data. A seamless system to report the cascade of care from countries to WHO. We would see on this slide that in 2017 and 2018, only 48 countries reported in 2017, only 42 countries in 2018. And I had the opportunity to lead a team to several countries to see how the hepatitis surveillance was being conducted. The 11 countries are listed on the right, and the objectives for this mission was really to assess the capacity of data systems to generate data for viral hepatitis. The main finding, the lack of national reporting tools and data systems for viral hepatitis testing and treatment. So though we are treating and testing, there is no way to report this data in many places. Sorry, I want to highlight several exceptions. And we found fragmented, non-standardized data systems in some tertiary centers. For example, in Tanzania and in South Africa, there's an excellent laboratory monitoring system where all the laboratory tests are reported and recorded. And it was amazing to see in that database new infections in children, infections in adults, and lots of infections in the country. I can really make that report available. In Uganda as well, we found an important national laboratory monitoring system because they had a program in place for viral hepatitis. And these are some of the pictures from the field. I particularly remember the middle picture, and you see all the paper data around. We were trying to extract treatment from those files, and it was an So some considerations for monitoring hepatitis: the need to update monitoring systems, the and linkages between facilities and the. We are now promoting community-based monitoring. Now, monitoring to capture outcomes from chronic hepatitis to liver cirrhosis and cancer, and between systems was a major challenge. Data confidentiality and security is an regular review is needed to use the data. WHO has really embarked upon to increase hepatitis reporting in the past 3 years. One is the development of a global hepatitis data collaborative with partners to harmonize technical assistance from multiple stakeholders, including the communities, the scientists, the clinicians, to support countries and coordinating and analyzing that data. In the 2021 report, which is widely quoted, this was due to the fact that 130 countries reported using this collaborative, and you can see the list of technical partners that contributed to this collaboration. And of course, the data use was prioritized using country data, and where that was not available, estimates from partner data and from the regional colleagues or the regional averages were used. There is a dearth of data of viral hepatitis in Africa. Again, there is a consolidated guidelines for HIV, and in the past 3 or 4 weeks, a new edition has been released and a section on recommendations for hepatitis monitoring within HIV programs. There are about 8 new hepatitis indicators in the HIV programs, and that will support hepatitis. And thirdly, the GAM data, which is traditionally for HIV. Now there's a new section with recommendation for hepatitis monitoring related to antenatal testing and hepatitis B PMTCT. This is a new system, and right now there are just a few countries reporting. The fourth thing I want to highlight in this presentation is lessons from the elimination pilot. WHO developed an elimination framework for countries seeking validation. So we're going to be like polio, where we can reach different levels of elimination and validation and global recognition for elimination. We did this in 7 countries with the objectives and methods on the screen. But one of the significant lessons learned was that we need to strengthen health data systems to enhance program data. And such strong program data can facilitate assessing impact and producing credible impacts or credible inputs for mathematical modeling, and we will see some of that today. I want to give a few examples, and one of the main examples for Afro outside of Egypt is Rwanda. Rwanda has decentralized hepatitis care with 560 facilities right now, and they have moved from paper-based data to Excel templates. Now they are working on their DHIS2 patient-level tracker. And these are the sources of data that has been built in Rwanda, and this is what their DHIS2 implementation journey looks like. And since we worked in 7 countries, just to highlight the information system from Brazil and Thailand working on data to strengthen the availability of data to monitor hepatitis progress towards elimination. We have produced country guidelines or country data pictures to show the results of the elimination pilots. So in terms of next steps, how do we improve global and country viral hepatitis data? Of course, we need to strengthen that collaborative that worked very well. We need to align partner data. We have international partners, we have global partners, we have regional partners, we have in-country partners, and all of that data can be strengthened and support countries. Right now, we're working on huge databases from China, Pakistan, and plan 2 priority countries per WHO region. And of course, we need to further consolidate and renew the hepatitis surveillance guidance and the country M&E. So, to summarize, and the take-home points from this presentation, that data and information are critical strategic directions of the global hepatitis strategy. All the presentations made prior to my presentation will not be possible without the availability of data. Now, reporting and monitoring using that standardized M&E framework developed by WHO with the 10 key indicators to support quality of services and improvement are important. Now, the national data and information are needed to make national decisions concerning viral hepatitis and the important role of partners and communities cannot be undermined. So there is a call to action, actually, which this is all about. And the Global Health Sector Strategy, the new strategy from 2022 to 2030, highlights important calls to member states, which is great. That's to Ministry of Health, but also to partners, to stakeholders, and to all of us in this room. And what are these calls? Number one, for members, we need that high-quality data. The second, we need to expand patient-centered monitoring to support these services from communities as well to be included. And we need to align these information systems to strengthen universal health care and to support the transition to digital information system. You saw the picture with the paper information system. It's an uphill task. So we call also on partners and stakeholders and all of us in this room. We need a joint effort and partnerships, international and local, to strengthen the SI systems, including population-based estimates, and the relevant disaggregation key to guide program implementation and quality improvement. And on that note, I say a very thank you for listening and acknowledge my colleagues and the Ministries of Health in the 7 countries that participated in the pilot and all of you for listening. Thank you.